Yeah, people will sit. Good morning. I'm Dr. Shilpa Ghuriye, the Healthcare Policy Officer and member of the Executive Board of the Indian American Cancer Network, IACAN in short. On behalf of the IACAN board, I would like to extend a warm welcome to all of you today. And thank you for registering to attend this educational seminar on colorectal cancer prevention, diagnosis, and treatment. Before we begin, I would like to recognize the organizations who are participating in this event: the Jain Society of Houston, Memorial Hermann Hospital Sugarland Campus, and IACAN. And just because many of you don't know who we are, I would just like to briefly go over what we do for the community. IACAN is a 501c3 nonprofit organization dedicated to the education and support of South Asian community, patients, survivors, and caregivers affected by cancer. We are a group of physicians, social workers, mental health professionals, cancer researchers, behavioral scientists, caregivers, and cancer survivors who have come together to provide services to the South Asian community impacted by cancer. Our mission is to be a cancer resource network that educates and supports through cancer education and awareness through our outreach programs, cancer prevention, and cancer support. For instance, we offer mammogram programs for our uninsured individuals. Please visit our website at icannetwork.org. Call us at 713-370-3489. You can also reach us on Facebook and LinkedIn. I would now like to invite Mr. Kalpesh Shah, Vice President of the Executive Committee of Jain Society, to say a few words.
Thank you. Thank you. Good morning, everyone, and a warm welcome to Colorectal Cancer Seminar organized by the IACAN nonprofit organizations. We at JSH honored to have the opportunity to address such a knowledgeable and compassionate audience today. Cancer is a disease that affects millions of people around the world and has touched the lives of many of us in one way or other. That's why it's important for us to come together to learn about the latest advancements in the research and treatment and to support each other in our journey towards a cure. Today's seminar will bring together some of the brightest minds in the field of colorectal cancer prevention, diagnosis, and treatment from Hermann Memorial Hospital, Dr. Amit Agarwal. I'm confident that you will leave here with a better understanding of the details shared by him. I would like to thank IACAN board members and their tireless efforts in organizing this event for their commitment in raising the awareness funds to fight cancer. So let's take advantage of this opportunity to learn, to share, and to make the difference in lives of those affected by the disease. Thank you, and I hope you will enjoy the seminar.
Thank you, Kalpesh-ji. Now I would like to invite Mr. Ronald Abram, the president of IACAN, to say a few words.
Thank you, Shilpa. Thank you, everybody, for coming, taking time out from your busy schedules on Saturday to come and be here with us. And of course, thank you, Dr. Agarwal, for sharing your insight on colorectal cancer. Shilpa has been kind enough to already explain what we do, who we are. So just to reiterate on that, we are basically here to help you and support anybody who's going through the cancer treatment and a survivor and also caregivers. So we are basically a resource that all of you can access, or anybody that you know who needs help in their journey. Our vision is to not have anybody travel that difficult journey of cancer treatment alone. We would like to help you in whatever way we can, and we do have resources that are available, and that is our mission as well. So thank you again for coming, and I'll hand it over back to Shilpa.
Thank you, Ron. Now I would like to invite Sandy Miller, Vice President of Oncology at Memorial Hermann. Say a few words.
Thank you. Good morning, everyone, and thank you for having us help today and participate with you in learning more about colon and rectal cancer prevention. At Memorial Hermann, we're committed to ensuring that you get the very highest quality cancer care, that you have all the support that you need along your journey. And to that end, today we have with us from Memorial Hermann some of our nurses and our program leaders. So when you have a moment, if you'd like to stop by and visit with them, they have some pamphlets, education materials to hand out to you. I really want to encourage you to listen closely to Dr. Agarwal as he talks particularly about prevention. There's a pathway to preventing colon cancer, and that is through colon screening. Colonoscopy is your #1 preventative measure to help you avoid and prevent colon cancer in your lifetime and for your families. We are a small but mighty group this morning, so each of you represents a family, a relationship, a partnership, a work environment. And I'm hoping that today you can take away some important new information about colon cancer prevention to share with your families and your neighbors and your loved ones. The last thing I'd like to say is that at age 45 is when we now start to recommend colon cancer screening. That has changed over the last recent years because of a higher incidence of colon cancer in a younger population. So I would urge you again to share with your loved ones, your family members, your coworkers, how to prevent colon cancer in your lifetime. It gives us great pleasure to participate today. And again, we're honored to be part of this relationship with IACAN, the organization that is here to support you through your cancer journey. In addition to that, I would just state again, our nurses at Memorial Hermann are here to walk with you every step of the way. Our mission for cancer care at Hermann is that no one faces cancer alone. And so it's our pleasure again to participate, and we encourage you to listen closely and learn all you can to share with each other and your families. Thank you.
Thank you. We have several programs lined up today for you. So we'll begin first with our seminar on colorectal cancer. Our speaker for this seminar is Dr. Amit Agarwal, a colon and rectal surgeon from Memorial Hermann Hospital and UT Physicians Group. Dr. Agarwal, welcome. The floor is all yours.
Thank you for having me. That was a great introduction by Sandy. So while getting the presentation put together, Amit Agarwal, colorectal surgery, been at UT for 7 years now, affiliated with Memorial Hermann, Sugar Land, and Memorial Hermann, Texas Medical Center, both. So originally, first generation here, my parents from Rajasthan, and they live in East Texas. So that's why the accent sounds the way it does. Oh. So I was invited to talk about colorectal cancer screening and surveillance methodologies. I had a patient that was going to come and talk to you guys today too. He's a survivor at the age, we'll get to it, but similar in age to some of the people in this room who had a screening colonoscopy that pretty much saved his life. And then I operated on him and he's doing well. He's 2 or 3 years out now. So. Oh. So colorectal cancer screening. So very, very important. It's the 4th most common cancer diagnosis in the U.S. Second leading cause of death from cancer. Nearly 50,000 people a year are diagnosed or death from cancers. Incidence is related to age, and we'll go over male and female shortly. So the incidence of CRC had been falling to 3 or 4% per year. for those who are 50 years or older, sorry. But there's a lot of data suggesting that there's an increase of cancer in younger age people. And so in 2018, the American Cancer Society changed the guidelines for screening colonoscopies to 45 years old. And so that's related to African Americans, especially, but other people at high risk as well. So anybody with a first degree relative who has colon cancer, or anybody that has what we call polyposis syndrome or genetic abnormalities can also get a colon screening at 45. So the goal of screening is to decrease incidence and mortality from colorectal cancer, prevent cancer, and improve our screening programs and modalities. So 50,000 colon cancer deaths a year in the U.S., and of that is 150,000 colon cancers are diagnosed. Okay, so 1 in 19 men, 1 in 21 women are diagnosed every year with colorectal cancer. In 2010, this is data, there was 3.3 million colonoscopies performed across the United States. So these are the guidelines from the 2018 that I was telling you about. So the American Cancer Society recommends anybody 45 or older who is average risk to undergo screening colonoscopy. There's other varieties where you can do stool testing. There's something called Cologuard, or there's a FIT test where you send in your stool and they test a immunoglobulin in the stool to see if there's any bleeding from your colon. However, if you are able to get a colonoscopy, medically fit, and can undergo anesthesia, I 100% tell you to get a colonoscopy. The reason is because colonoscopies can be therapeutic and diagnostic at the same time. So say that we find something in your colon, a lot of the times we can take it out right then, right? And get the pathology, we move on, right? You're able to visualize the entire colon through the procedure and see exactly what's going on. With the other test, if your Cologuard comes back positive or your FIT test comes back positive, you still need a colonoscopy. So now you've done 2 tests, right, with the same result. So if you can get a colonoscopy, you're medically fit to get one, go under anesthesia for a small bit of time, you should definitely get a colonoscopy. These are the stool-based tests I was telling you about. So if you decided, or you could not get a colonoscopy, you should get a stool test every year from your primary care doctor. And then a colonoscopy, depending on what you find in your first colonoscopy, determines the interval of the colonoscopy. So it could be 10 years, could be 5 years, could be 3 years. It all depends on the number of polyps and the pathology that comes back from the polyp. We talked about FIT. Okay, so when you go to your primary care doctor, and a lot of you guys do, they do what we call a fecal occult blood test, right? And so where they take some of your stool and they smear it on a card and they drop some a liquid solution on the card and they tell you, hey, it's white positive, yes, no, you have some stool in you have some blood in your stool. But what does that mean, right? Does that mean that you have cancer? Does that mean you have hemorrhoid bleeding? What does that truly mean, right? And so there's some other stool tests, if you're going to get one, that you should probably get is more sensitive. It's called a FIT test, fecal immunochemical test, right? So it really diversifies, or it tells you exactly where that bleeding could be coming from. It's very, very much more sensitive. So if you have to get a stool test done, you should ask for a FIT test. A lot of your primary care doctors already know about this. So when I go back to the colonoscopies and occult blood testing, with swiping your stool on a card and putting some liquid on there, there's a lot of false positives, right? And so how do we avoid all these false positives, right? And so we're thinking about, people that eat meat or have ingestion of broccoli or high fiber foods, or some people that had like a nosebleed and the blood that goes into their mouth, it goes into their stomach, that goes into the colon, can all come back as positive. But those are false positives. People that use a lot of aspirin or blood thinners or NSAIDs can also have a false positive result on their stool test. However, you can avoid all these things if you get a colonoscopy 30-minute procedure, you do a bowel prep before, then all these negative things that you think that are positive are eliminated because you're actually seeing through the colon, looking for things. So anybody that has a high risk family history, not associated with a polyposis syndrome, that's what I was talking about earlier, the recommended screening goes up to 5 years. So instead of 10 years, you should get a colonoscopy every 5 years. So anybody with a first-degree relative that has colon cancer or a strong family history of colon cancer, anybody that has multiple polyps with pathology showing high-grade or advanced precancerous polyps should also be getting a colonoscopy every 5 years. So what's the difference, right? So most of us are going in for a screening colonoscopy, right? So screening by definition means you're scoping for otherwise asymptomatic patients. So these are routine things, right? The things that you should be getting done for your own surveillance. Women get pap smears, get mammograms, right? And so men and women should be getting screening colonoscopies. Diagnostic colonoscopy means that you're doing the colonoscopy or endoscopy for a clinical symptom that led you towards this stage in management. So somebody that has full-blown rectal bleeding, or they get blood work back and their hemoglobin is low, that's called anemia. Or if you get a CT scan and it shows some kind of mass in the colon, then you're getting a diagnostic colonoscopy. So anybody that has these red flag symptoms on your blood work should definitely talk to their primary care doctor, or the primary care doctor should talk to somebody about getting them a colonoscopy. So if you have unexplained weight loss, lots of constipation, changes in your stool caliber. So say that your stools should be normally soft and bulky, and they come out like a log, and then over time they're becoming more splattery or pebble-like or pencil thin. Those are changes, right? What is causing that change in your stool to come out that way? It needs to be addressed. And on your blood work, there's something that we call anemia. That's your hemoglobin being low, but there's something where we look at the iron studies, and if your iron is low and your hemoglobin is low, we call that iron deficiency anemia. Those are red flags for you to get a colonoscopy. There's always risk of getting a colonoscopy, right? These are very small, less than 1%, right? And so there's some cardiac issues. You could, the perforation, bleeding, all less than 1%. You can have aspiration while you're going to sleep, but these are very, very small risks that we talk about when we schedule you for the colonoscopy. So this was my point where I was going to talk about the patient. So Indian origin gentleman had his first colonoscopy about 58 years old. Only symptoms that he was having was feeling tired, a little bit more fatigued, just wasn't eating as well. Went in for a screening colonoscopy and was found to have a left-sided or a sigmoid colon cancer. Biopsies were done, proved the cancer. Then we got some staging imaging, CT, chest, abdomen, pelvis. Did not show any disease in the liver or the lungs. So then he came to me and we discussed his cancer, and he ended up having surgery. And so we removed that portion of the colon, we connected it back together, and his final pathology showed stage 2 colon cancer. And so he's currently now 3 years out and doing really well. Did not require any chemotherapy, did not require any radiation, anything like that, right? And so if you go back and think about it, the only thing that potentially saved his life was his colon cancer screening, like his colonoscopy. So I always give an example. See a 50-year-old man in the clinic, you recommend a colonoscopy for colorectal cancer screening. Where should you send your patient for the colonoscopy? So who does their colonoscopy is very important as well. So ideally, you want to send it to a person that does a lot of endoscopy. And so we call those people a colonoscopist, right? And so we want somebody that's safe, effective, who detects polyps, right? And who resects them at the same time, if you can, right? Safely. Reality is that most of the time you get sent to a variety of different people, right? And you don't know what their detection rate is, what the resection rate is. You just trust your PCP and you go, which is fine. So when you talk about quality colonoscopy, and that's what we're talking about here, right? So we talk about preparation. We want it to be excellent, right? So if somebody tells you do a bowel prep to clean yourself out, you definitely want to follow the rules and do the bowel prep. There's multiple bowel preps you can do. A lot of people are hesitant about getting colonoscopy because of the bowel prep. And so there's now used to be 4 liters of liquid that you had to drink. My preference and what I do for all my patients is we give 14 ounces of bowel prep. And that's done over a 1-day period. So you do 2 doses at nighttime the day before your colonoscopy. So it eliminates 4 liters, comes out to be a little bit more than a Coke can. And if you do it correctly, your preparation is very good, or your bowel prep is very good. And so when we do a colonoscopy, we talk about how far did you get, right? You want to look at the entire colon. So the right side of the colon is called the cecum, and you want to photo document that. You want to make sure when you withdraw from the colon, you look at every fold, every portion of the colon. There's many regions of the colon that we have different names for, and it should take you anywhere between 6 and 8 minutes to take the colonoscope out and visualize the entire area, okay? And so we talked about looking at the walls and behind the folds. And if you're going to see a polyp or a growth in the colon, you want to be complete and safe when you resect it, right? So when you take it out, you want to make sure that, you're not getting too deep or you didn't leave anything behind. And so that all goes back to who's doing your colonoscopy. And then recommendations for the follow-up is based on what you find during the colonoscopy, right? We talked about 10 years, 5 years, 3 years. It all depends on what you find and what the pathology shows. So this is my tip guide to screening and surveillance colonoscopy. So should be done right. The anal region or the area around the anus should be visualized, and a rectal exam should be performed before you put your colonoscope in. So it's not a race to get to the end, right? So safety is key. You want to make sure you see the entire colon, right? You have to wash sometimes if it's a little bit dirty, but again, if you do your bowel prep correctly, you don't have those problems. Look at all folds, behind corners, and you want to make sure that it takes 6 to 8 minutes for you to have your entire colonoscopy withdrawal done. And then there's on the bottom line in retroflexion, we talk about looking in the rectum. So that's where we can look at any rectal pathology, anal pathology, or make sure that we don't miss any polyps or lesions. Just as some more data about withdrawal times. So there's a for the time that you take. So the longer you take, most people say it's a 1% increase in polyp detection rate, right? Associated with a 5% decrease in colorectal cancer. So the more polyps you find and take out, the better off you are about decreasing potential colorectal cancer, right? Because every polyp that stays in there too long can turn into cancer at some point. Usually average time for a polyp to turn into cancer is anywhere between 3 and 5 years. Won't go over this too much. This is more of for the physicians and why we have different grades of polyps and what that means. But what it means for you is if you had something, what we have right here at the very bottom in 2B, sessile serrated, then that means that your colonoscopy interval is going to be much shorter than most people's, right? And so all the other ones up here on 1B, those tell you that you are precursors to cancer. They're not full-blown cancer, but if you leave them in long enough, they will turn into cancer. This is surveillance intervals. I kind of briefly went over that with you. There's a lot of stuff on this slide. This is from 2012, and this has stayed the same throughout. So I know I went through the talk quick. My survivor was supposed to talk a little bit too. So in my conclusions, right, colonoscopy prevents colon cancer and deaths. Very, very important. I can't stress it anymore. Quality screening reduces the risk of interval cancer. So depending on, like I said, who you go see is important. We have a lot of great GI doctors and surgeons at Memorial Hermann affiliated with UT that your primary cares know about. So if you were to see any of them, I'm sure everybody would do a great job, okay? And removing the polyps can avoid surgery, but the polyp has to be removed completely, right? If it's left behind, then there's a chance you're going to need surgery at some point, okay? Thank you. Any questions that you have, I'll be happy to answer.
Oh, okay, good. Where's the other one? Oh, okay.
Thank you. On the last slide, you had this quality resection. What does resection mean?
Are you talking about the third bullet point?
The third
Okay.
bullet.
So that when you're doing a colonoscopy, what that means is that when you see a polyp, you take the polyp out. Resection means removal. Yeah.
Okay. And then there was something about capped insertion.
Endoscopy?
Yeah.
Yeah. So what that means is, when you do cap endoscopy, so you put a cap on top of the colonoscope, right, when you insert it in, and so you're able to see the polyp more clearly. It's more advanced technique or technique people use to get the entire polyp out. It makes everything else in the colon not visualized except exactly that area.
I just want to ask whether this coloscopy screening is covered by government or is covered?
So when I talked about the guidelines, right, the American Cancer Society 2018 moved the criteria down to age 45. 100% covered by your insurance.
But I talked to my doctor. He says, no, it's not covered. You have to pay something for that.
That's
Because last time when I did in 77, 5 years back, so it was all covered.
Right.
I didn't pay anything. But now he's asking something to pay. I don't know how much he's asking. And he says it's not covered. That's why I was just,
screening colonoscopies are
Yeah.
covered, right?
okay.
It depends on what the findings were from the prior colonoscopy, right? So when I say screening, that means that they didn't take any biopsies, they didn't do anything like that. You didn't find any polyps. That's covered. Sometimes if you find polyps and you remove them, then you have to pay whatever your deductible is, right? Or a percentage.
Okay.
That's the
If
difference.
polyp is there.
Correct.
But if there's no polyp,
Then if it's screening and nothing is found, it's 100% covered.
so can you please give me your phone number so that, because I'm almost to do, because I did in 77, just 5 years.
Sure.
I had one polyp that was removed in 77.
Uh-huh.
Now I'm supposed to test again. So I would like to.
Sure.
And
We'll get him some cards. I didn't bring any actually today, but okay, perfect. She has some over there. Thank you.
thank you very much.
At what age we should stop all this, colonoscopy and all these tests?
So truly depends on what your previous colonoscopy showed, but by the age of 80, right, we say that you don't need any more colonoscopies unless you're having problems, right? So rectal bleeding, weight loss, changes in bowel habits, then you get your colonoscopy. But usually 80 is about the normal guideline. Some people say 75, but it's been back and forth between 75 and 80.
Okay, thank you.
No problem.
Yeah, it was a great talk. Thank you so much. Pardon my ignorance, but can you please elaborate a little bit on the polyps, what polyps are and how do we understand those?
I apologize, sorry. So polyps are growths in the colon, right? And when you have a growth in the colon, it's almost like having a grape grown off a vine, right? So if the colon is the vine, the grape is the polyp, right? And so over time, people will have polyps. Everybody in this room will have a polyp at some point, probably. But the point is that when you leave a polyp in there for too long, the cells turn over and they can become cancer, right? And it takes 3 to 5 years for that to happen. That's why we say screening colonoscopy is so important. So even if you see a small polyp, a benign polyp, you take it out so it doesn't have the chance of turning into a cancer. Okay.
Thank you.
Thank you, Dr. Agarwal, for the valuable presentation. From the public health perspective, I'm
Can you
wondering.
speak up a little bit? I can't hear you.
Oh, sorry. From the public health perspective, I was wondering, are there any studies related to the, like if some certain populations are more prone to this cancer, like by ethnicity or region wise?
Absolutely. That's a great question. So, in 2018, the guidelines were changed because African Americans are more prone to colon cancer. But I would also say, based on diet alone, right, we're seeing colon cancer in a younger age population. So this week, I'll give you an example: Hispanic patient, 37 years old, colon cancer. Saw another Hispanic person that was 23 years old with colon cancer, right? And so the Indian subcontinent is definitely not exempt from this either, right? And so when we talk about diets, people that eat lots of red meat up higher, right? People that eat a lot of processed foods up higher. People that smoke, drink alcohol, don't exercise, overweight, also much higher, right? And so colon cancer just is not exempt any ethnicity, right? You just see it more in certain ones because of socioeconomic status or what their diets entail.
So, if you are less than 50 years, like my son, and he does PSA test, and that is doesn't do, so there is to do this screening.
So PSA is completely different than this. PSA is for your prostate. Has nothing to do with your colon, okay? All right. No, it's okay.
Great talk. So you partly answered the question I was going to ask you about the dietary modifications, but can you comment specifically as you grow old, along with dietary modifications, any other lifestyle changes which can help with reducing the risk along with the preventive screening?
And so I think you answered your question yourself, but I would say, the more dietary changes, so less meats, more fiber, more exercise, we say, 3 times a week, 30 minutes each time. So you increase your cardiovascular health, right? Will then also prevent you from potentially having colorectal cancer. And then I would also like to say that, colorectal cancer is 50% sporadic, means that it just happens no matter what you do, right? 50% is genetic, right? And so if you have the genes, no matter if you changed your diet and you exercise 7 times a week, you're still going to get colon cancer at some point, right? And so, diet, exercise are 2 main things that you can do. And meats, especially processed foods, red meats, are the ones that will get you in the end.
What is the best age to start screening for the cholesterol?
45.
45.
Correct.
Not 50.
Correct.
So maybe just to reiterate what you said, and you can expand on that one in the sense that you may not have any obvious symptoms of even initial stages of colon cancer, but there may still be some polyps inside there. Therefore, screening could even help you to preempt that one and maybe get on a better path to not getting the cancer. Right?
Correct. So colon cancer or colonoscopy is preventative, right?
Exactly. So that's what I want to make sure.
The word we're looking for is preventative. How are we going to prevent the colon cancer? Well, you can't prevent it if you don't get the procedure done, right? So
that's why I think there are few cancers for which we have this opportunity to actually prevent it.
Correct.
And colon cancer is one of those things where it's in our hands to do that.
So for a man, prostate exam or PSA helps. Women have mammograms, pap smears, but this is the one where you can do men and women and be preventative for colorectal cancer.
Wonderful. Thank you.
The colonoscopy was done about 1 year ago, 1.5 years ago. There were 3 polyps, which are precancerous polyp known as tubular adenoma. And some blood was also coming in urine, some traces of blood were coming in urine also. So I want to know what precautions I should take. I'm 78 plus now. So I want to know what precautions I should take to avoid any such a thing happening more.
There's no precaution.
Is there anything I need to do now? Because
Nothing.
doctor told that you have to again come after 5 years for the colonoscopy.
Sure, I don't think you can prevent. So if your polyps are gonna come back, they're gonna come back, but the only way to know for sure is you get your colonoscopy in 5 years, right? And then anything you do now is not gonna change it happening. So if he told you to come back in 5 years to get your colonoscopy, then you should go and talk to him about it.
Does one need to do endoscopy too with the colonoscopy, or just the colonoscopy itself is fine?
So it all depends. If you're having upper GI symptoms, like trouble swallowing, lots of acid reflux, heartburn, things like that, people will do the endoscopy at the same time as the colonoscopy. But if you're not having those issues, you don't necessarily need to get an endoscopy done.
Okay, and how does one prepare? You said something about drinking just 14 ounces. They used to give a whole gallon of something to drink.
So there's different types of preps for your colonoscopy, right? So the one I give is 14 ounces. Some people, depending on who you go see, right, will give you the 4 liters. It's much cheaper, right? But it's also 4 liters of liquid to drink, right? So it causes lots of bowel movements, dehydration, headache, can be, right? And so 14 ounces does the exact same thing 4 liters does. Okay, but it all depends on what your insurance is going to cover.
Oh.
So,
one last question. What is the worst side effect? I mean, the worst case scenario that could come out by doing like bleeding or something?
I can't hear you.
Any kind of bleeding when you do the colonoscopy?
Yeah, absolutely. If you take something out, the chance of them having bleeding is there, but it's less than 1% because we see it at the same time we're taking something out. Very small chance.
Okay, thank you. Right, complications of the colonoscopy itself.
Sorry, I missed that.
Complications of colonoscopy, the procedure.
Right. So the ones I listed up there, bleeding, making a hole in the colon as you maneuver the scope around. All those are the 2 main ones, right? And both of those are less than 1% chance of happening.
Okay, thank you.
Dr. Agarwal, I think the concern as non-medical people is we are trying to, there's a general, we are scared of any procedure, right? And we tend to put it off as long as possible. But as part of the message we want to hear from is the discomfort as significant as the risk? I think, there is some discomfort in anything. So that's the point of that question, I think. So we want to just get reassured from somebody who does this on a daily basis that, what do you see? What are the worst case?
Right, but we try to limit the discomfort with the prep by giving you a small volume prep to clean your colon out. And then, there's things that we do to take the air out at the end and, minimize any type of complication that we may have, right?
Yeah.
But any procedure, right, there's always a small chance of.
And most people can get back to their routine in a day or 2.
No, you wake up from your colonoscopy, you're tired for about 2-3 hours and you're on with your normal life.
Perfect.
Right afterwards.
That's exactly what we all want to hear.
I tell everybody just to take the day off of the procedure, go back to work the next day.
Fantastic.
So.
My voice is loud enough, so I'll just leave it that way. So my question was related to the point of reaching that. So I go to my doctor, my physician says, okay, this is the list, this is the person I want you to visit. But to emphasize a few times, the right person to do the procedure. So should I just rely on my doctor, or can I is there a site I can go to Google up? What would you say? How would I know that my doctor is recommending the right person for the procedure?
So it all goes back to your relationship with your primary care doctor, right? So how long have you been with them? If you've been there 1 year, okay, maybe you trust them, maybe you don't. 20 years, probably you trust them, right? And so I think that's a decision you need to make. There's no website that's going to tell you this is good, this is bad, this person's good. But I mean, if you go look up the person they send you to, right, you'll be able to see all their credentials and where they go and what they've done, so on and so forth.
Let me correct myself. Are there any specific points that I would see that this person has done enough time during this meeting? You might mention a few times.
You won't see that.
So I have a quick question here. So whenever we hear something being removed, it kind of makes us nervous. So what does it mean to have polyp removed? How invasive it is, or discomfort, etc.?
You will never feel a polyp being removed because you're completely asleep. When you wake up, you still won't know that it was removed until we show you the pictures. And so it's very minimally invasive, meaning that the only time that you even know that you're having it done is when you go to sleep for the colonoscopy and you wake up for the colonoscopy. And when I say we remove it, it's removing from the inside of your colon, right? Like I said, if you would have never known that we did it until we show you the pictures. Okay.
So always the general anesthesia is administered.
It's not general anesthesia. It's called total intravenous anesthesia. We give it through the IV, and then we put you to sleep that way. There's no mask, there's no tube, nothing like that. Thanks.
I think two things I just wanted to clarify. One, I think the fear of colonoscopy, especially for folks who've seen or heard about it back home, it's very stressful. Meaning, patients don't get sedated really well. Like my dad had it in Hyderabad and I could hear him moaning through the room. It's awful. So I think that's one of the fears of wanting to go through a colonoscopy. The second thing is, I think, the complications, right? So you hear about something bad happening to someone. I think assurance really helps. I can't tell you how many times Indians here who are really well educated, this is the one component that we have to reiterate, go get your colonoscopy, get your CT scan, so I think it's not the lack of education, but I think just the not knowing what to expect is what makes it makes it a lot more difficult for patients to actually seek care, especially in regards to colon cancer screening. The other question, I think, was about where do you go to find the physicians? There's actually no website, like Dr. Agarwal said, where you can actually go and find people. But most physicians who go through gastroenterology training, on an average, they do at least 1,000 to 1,500 procedures per year. So by the time you're done with your training, you've done enough that you're actually very comfortable scoping patients. Now, there is always a concern about really big polyps. Smaller ones, anyone will take them out. Bigger polyps, you actually want to see someone who's a specialist, because those are the folks who are in between general gastroenterologists and Dr. Agarwal. So there are specialists who are specifically trained to take bigger polyps out without needing to go to the surgeons. But that's the decision you make with your GI doctor, with your surgeon, and that advanced endoscopist is who we call those specialists, and they are able to take out bigger polyps. But again, I think it goes back to talking with your primary care physician and your gastroenterologist.
I just had, that was good commentary. But I would add, I don't know what your practice is like, but we are in mind, and all my partners and the GIs I know, we don't use Versed and things like, we don't do conscious sedation anymore. Everybody gets propofol, right?
Yeah.
And so,
same here. Yeah.
And so then there's no moaning and groaning. They don't remember these things. And so you move through the procedure quickly,
and
right?
You wake up after that's what I tell patients. I say, you
don't remember
won't feel
anything.
a thing. You won't feel a thing. You're going to be put out and you wake up, and that's what happens. And I'm a transplant hepatologist. I do a lot liver cancer more than general GI. But I tell my patients, you're going to talk with your doctor, and the next thing you're waking up in the recovery area, you won't remember a thing. And you're very comfortable. You just go home and take it easy, watch TV, shop, whatever, and then go back to work. Next day, don't drive. That's all we say. So it's very, very, very easy, 30, 40-minute procedure, and it saves lives. So yeah.
Okay, let's get the mic. No. We're recording this. So I think every question, the answers are really important for a wide community. Thank you.
Thank you for coming and enlightening us with this very important subject. The question I had was, I'm a 2-time cancer survivor, and I'm being told that I have to have one colonoscopy every 5 years. How long will that be until, do I have to continue doing it for 5 years until I'm 80?
Yes, that would be the guidelines, correct. And so I'm not going to put you on the spot and say what cancers you had, but you know, if you had a colon cancer, that was even more important that you get it done every 5 years, and how far you are out from that if you had colon cancer, right? Because the way we do it currently is if you have colon cancer and I do your surgery, then the next colonoscopy is 1 year from the surgery date. If we find any more polyps, it's every year till we clear the entire colon,
I see.
right? And if say that we did your colonoscopy at 1 year, there's no polyps, then we move you out to 3 years. Then at 3 years' time, if there's no polyps, then we move you out to 5 years. But 5 years would be the most you would ever go without getting a colonoscopy.
Okay, I had breast cancer and thyroid, so
Okay.
it's been, I've already had two. I'm due for another one now. But just
Definitely 5 years for you then.
yeah, just to let you know, this is the easiest procedure I have ever done. And it's the best sleep you're gonna get. So if that helps you, go for it.
For those who don't know Ashma, any question ever, please don't hesitate to ask her. She'll help you. Any other questions?
So something about polyps, I don't know much about it, but if I had like a polyp, non-cancerous polyp during my pregnancy, like uterine polyp, does the body have a tendency to grow polyps somewhere else? Does that happen?
So the uterine polyp and a colon polyp completely different. Cell type is different, histology is different, everything's different, right? And so just because you had a uterine polyp does not mean you're going to have a colon polyp.
There's no like
There's no connection.
chance or risk
No.
like that. Thank you.
Thank you so much for sharing such a great information. And just for the reinsurance purposes that somebody said that our community is definitely concerned. So I had my colonoscopy a few years back, and after that I was like, oh, done, nothing. So I was like, I was prepared that maybe I need to take a rest or something, but of course it was easy for that. Now I'll move to my question as, is there any genetic marker testing available, like for the mammograms? And we do have those testing available. So do we have this kind of testing available?
So yes, there is genetic testing available, but we do the genetic testing after we get a diagnosis, right? And so you have to get your colonoscopy done, right? To find the polyp or the cancer. And then based on age, there's a bunch of stuff that we can do. We can send the polyp for genetic testing. We send your blood for genetic testing. Then if you need to see a genetic counselor, we get you in to see them too. But there's all these things are set to be done, but we have to get the diagnosis first, right?
Thank you.
Yeah, I had a question about the bowel prep. So with somebody with a lazy bowel syndrome or where it's not fast enough, how does that work? The 15-ounce fluid you recommend?
So on occasion, if we know that you have chronic constipation or you don't have bowel movements every day, we may split your bowel prep into 2 days, right? And so you do it 2 days before the colonoscopy, so we know for sure we're clearing you all out.
Okay. Thank you.
Mm-hmm.
Yeah.
I remember another colleague of mine who's a colonoscopy specialist used to say, this is what you call wash and dry cycles, like in the washer. So you wash it up so that everything is clean for the colonoscopy to actually see and do the best diagnosis possible. So that makes sense.
Thank you again for your time and your attention.
Thank you, Dr. Agarwal, for the useful information you have shared with all of us today. I would now like to invite Gayatri Kapoor to come up and say a few words about Be the Match. Be the Match is an organization that is a global leader for bone marrow transplantation, and Gayatri ji is the recruitment coordinator for this program.
Thank you, Shilpa. Yeah. So we learned a lot about early detection and the treatment for the colon cancer. And cancer is one thing we are very scared of it. We do need a lot of medical treatment when you go through any kind of treatment. But the blood cancer is one thing. where we do need help other than the medical professionals as well, because these patients need blood forming cells from a matching donor, and that cannot be manufactured in a factory or any lab or anywhere. So we need people who are willing to share the wealth of health they have by just giving their cheek swab samples. So what is it? We maintain the database of millions of people who are willing to donate their blood stem cells. I would like to ask a question. Anybody knows how many millions of people we have in the donor database who are willing to donate? Give me a number. Anybody? Give me a number. Yes, we have international database too. We have the national too. Give me a number for international or national. Anybody? Give me just one number. It's in millions. 100 million is a dream, but we do have 11 million people in the donor registry, but still we struggle to find matching donors for patients. The reason is these genetic, the HLAs, the hemoleukocyte antigens that needs to be matched, these are very complex. So 1 in hundreds or thousands match. And on top of it, ethnicity plays the bigger role, because these HLA who are transferred from generation to generation, the patients, it means, who need the transplant have a better chance to match someone from their ethnicity. We have 11 million in the national registry, and majority of them are white. So for any ethnically diverse patient, finding a matching donor is a huge, huge challenge. One child, he was born with beta thalassemia. Many of you already know him. His name is Rushi Gandhi. It took him 10 years to find one matching donor. So you can imagine how difficult it is for somebody to find a matching donor. Fortunately, he did not have blood cancer. He had blood disorder. So he could survive on blood transfusions until he found a matching donor. But when somebody has blood cancer, doesn't have that much time. Even though we have the best of the best treatment, we have really great doctors, really good treatment at MD Anderson Methodist, but the problem is we do not have enough donors. Even though becoming a donor is super easy, it's a simple cheek swab test, and any healthy person is eligible to take that test. It just takes few seconds. You fill up a form on the phone, give the swab samples, and done. You stay on the registry until you turn 60, and if you match, you have the chance to save a life. It is that simple, but still, we need more and more people because 11 millions are not enough. So I encourage anybody who is eligible, give samples. And if you have given samples, or if you are not eligible for one reason or the other, it doesn't mean that you cannot help. There are so many ways that you can still help. In our culture, we have saying that it takes a village to raise a child. So the same way over here, to find one matching donor, we need hundreds and thousands of people help. You might be part of the organization or part of the group. There are hundreds or few young eligible people. You can connect us with those groups and we can educate them and give them opportunity to sign up. And now the things are super easy that we do online as well. We provide information online. You can get the kit in mail, and that's it, super easy. So no matter at what stage you are, you have the potential to be part of someone's cure. So reach out to me if you know any organization or any other ways that you want to help. Once again, thank you. What? So we have been partnering with IACAN for last, I think, since 2010. And a few hundred, not in the 100, I don't know how many thousands people have signed up with the help of Indian American Cancer Network. So it has made so much change. Like in the National Donor Registry, the availability of South Asian donors is around 25%, but in Houston, greater area, availability of donors is 85%. So that is all because of the great work IACAN is doing, but it is saying that we still need to do a lot more work. So we really appreciate any kind of resources that you can provide us. And so that the work that ICAN has started in Indian community, we want to keep doing that and extend this to the other cities so that we can provide better hope for our patients. Thank you.
Thank you, Gayatri ji. Now we are going to be joined by the dance performers of Jain Pathshala. They are led by their teachers Chaital Shah and Chini Mehta. Our thanks to the performers and the teachers.
Thank you, Dr. Shilpa and Dr. Amit Agarwal for the great presentations you had it on the health seminar. Now I would like to have some cultural activities from JSH. There are two kids are performing here today. One of them is Khushi Kavedia. So I would like to invite his dad, what she's going to perform and what is the benefit of that specific performance in the health. That's an alternative way, like, you can always follow the medicals, but there are alternatives way to reduce your pain. So that's what she's going to perform. So let me invite his dad, what she did, and then how she's going to perform. Jitesh, yeah.
Jai Jinendra, or hello. Great talk, Dr. Agarwal. Yeah, I'm scheduled for my preventive colonoscopy, and you really eased my mind what to expect. So Khushi, she's going to sing Bhaktamar Sutra. And this was a sutra which was composed by Sri Acharya Manatung Suruji in 700 CE. So Khushi learned this sutra during the difficult COVID times. She wanted to learn a sutra which is going to uplift her spirits and also increase her spiritual knowledge. So we encouraged her to learn this Bhaktamar Sutra because how important it is. It has 48 shlokas, and each and every shlok has its own meaning. So today, out of those 48, she's going to recite shlokas which can help and provide some health benefits and improve physical well-being. So thank you everyone for coming, and thank you JSH and all the organizers for this opportunity. Thank you.
So before I begin, I will be starting with Nokar mantra. So please fold your hands and close your eyes. Om Namo Arihantanam. Om Namo Siddharnam. Om Namo Yariyanam. Om Namo Jayanam. Namo Loe Sav Sahunam. Eso Panchanamo Karo. Sauva Papa Nasano. Mangalarnam Char Salvesim. Padhamam Havai Mangalam. Padhamam Havai Mangalam. Bhaktamara Pranatamolimani Prabhanam. Mudyotakam Dalita Papatamo Vitanam. Samyak Pranamya Jinapadhayugam Yugadha. Valambanam Bhavajale Patatam Janana. Yasanstutah Sakalvangmaya Tattvapodha. Dudbhuta Poti Patubhi Surlokanathai. Stotre Jaga Tritaya Chitta Hari Rudha
कुशीकिलाहमपितं प्रथमं जिनेन्द्रम् बुद्ध्या विनापि विबुधार्चितपादपीठ स्तोतुं समुद्यतमति विगतत्र पोहम् बालं विहाय जलसंस्थितमिन्दुबिम्ब मन्यः क इच्छति जनः सहसा ग्रहीतुम् नास्तं कदाचिदुपयासि न राहुगम्यः स्पष्टीकरोषि सहसा युगपजगन्ति नाम्भोधरोधर निरोध महाप्रभाव सूर्यातिशायि महिमासि मुनीन्द्रलोके छत्रत्रयं तव विभाति शशाङ्ककान्त मुच्चैस्थितं स्थगितभानुकर प्रतापम् मुक्ताफल प्रकरजाल विवृत शोभम् प्रख्यापयत् त्रिजगतः परमेश्वरत्वम् गम्भीरतारवपूरित दिग्विभाग त्रैलोक्यलोक शुभमन्नन भूतिदक्षः सद्धर्मराज जय घोषण घोषकः सन् हे धुण्डुभिर्वनति ते यशसः प्रवादी मंदार सुंदर नमेरु सुपारिजात संतानकादि कुसुमोत्कर हृष्टिरुत्था गंधोदपिंदु शुभमंद मरुत्प्रपाता दिव्या दिवः पतति ते वचसां ततिर्वा उद्भूत भीषण जलोधर भैरभूग्नः शोचां दशा मुपगताश्च्युत जीविताशः त्वत्पाद पंकजरजो मृत दिग्ध देहा मर्त्या भवन्ति मकर ध्वज तुल्य रूपः आपड कंठ मुरुशृंखल वेष्टितांग गाढन बृहन् निगड कोटि नृहृष्ट जंगः वन्नाम मंत्र मनिषं मनुजः स्मरन्तः सद्यः स्वयं विगत बन्ध भया भवन्ति मत्त द्वीपेन्द्र मृगराज दवानलाहि संग्राम वारिधि मोहो दरबंदनोटम तस्याशुनाश मुपयाति भयं भीवा यस्तावकं स्तवमिमं मतिमानधीते स्तोत्रस्रजं तव जिनेन्द्रगुणैर्निपथा भक्त्या मया रुचिरवर्णविचित्रपुष्पा धत्ते जनो य इह कण्टगतामजस्रम् तम्मानतुङ्गमवशाय समुपैति लक्ष्मीः तम्मानतुङ्गमवशाय समुपैति लक्ष्मीः तम्मानतुङ्गमवशाय समुपैति लक्ष्मीः जय जिनेन्द्र
Thank you, Goshi, and thank you, Jitesh, for preparing her for this specific performance. I appreciate that. Khub khub anumodna. Next one, we have Ansi Shah. On a lighter note, she's going to have one of the musical performance. So hope you will like her dance. She's going to perform. Appreciate her parents too for appreciating her to come to the stage. Thank you.
हमने मोहब्बत करनी है, हमने मोहब्बत की है, इस दिल के अलावा किसी से भी ना हमने इजाजत ली है। हुनर है ये भी इश्क का, किसी किसी को आता है, जान लुटा के दुश्मन की हमने हिफाजत की है। बात करते हैं हजारों, तजुर्बा हम यारों, बात करते हैं हजारों, है तजुर्बा हम यारों। ऐसी है बांध लूं मुझ पे वो, झूमे जो पठान मेरी जान, महफिल ही लुट जाए, दे दे जो जुबान मेरी जान, उस पे मर मिट जाए।
Well, thank you to the performers. Before we end today's program, just a few thank yous. Can you hear? I hope that the seminar today was very helpful to all of you, and I also hope that you will join IACAN in our future events. We are here to help our community, and as Ron had mentioned and some of the other speakers had mentioned, we truly believe that no one should feel that they're alone when they have to deal with this disease. I would like to thank all the attendees for taking the time on a Saturday to join us for this seminar. Thank you, Dr. Agarwal, for sharing valuable information with us, Sandy Miller for joining us today, and Memorial Hermann Hospital's Sugarland campus for collaborating with us for this event. If you want more information regarding colorectal cancer screening, please talk to the nurses at the Memorial Hermann Hospital table. We also have flyers that contain information in Gujarati if you need some. Thank you, Gayatri ji, for all that you do for our community and for being here today to talk to us about the importance of bone marrow donation, especially for South Asian community. I would also like to thank the students and teachers of Jain Pathshala. Many thanks to the Jain Society of Houston and their board members for giving IACAN an opportunity to present this educational seminar. Special thanks to Mr. Kalpeshi of JSH and Dr. Mona Lisa Chandra, past president of IACAN and current board member, and Deepika Varya, treasurer and executive board member of IACAN, for organizing this event today. Special thanks to Sanjay Shah, who's in charge of kitchen and for catering the lunch for this event. I would also like to thank IACAN board members for attending this event and for their support in organizing outreach activities. Last but not the least, thanks to our media partner, Indo-American News, for helping us promote this event. Thank you.
Thank you, Dr. Shilpa. I would like to thank IACAN, Dr. Amit Agarwal. Also, I would like to thank our JSH member and one of the Dr. Ragini Ben Lakia. She inspired us to have this seminar at the JSH. So a lot of her effort went from her to bring this seminar in the JSH. So definitely a good thanks to Ragini Ben and thanks to Deepika Ben for coordinating with IACAN, like, can we have the seminar at the JSH? So this is our first seminar after a long time we have it in the JSH, and we are going to have many more going forward. So stay tuned. There will be a lot more seminars will happen going forward. Thank you. Another thank I would like to, IACAN has sponsored a lunch today at GSH. So we have a lunch outside. You can take the lunch outside, and there's a dining area. You can sit in this dining area and have your lunch. Thank you. Thank you, everyone.